I was hoping that I can go through with you some of the challenges in caring for patients with traumatic brain injury from the trauma surgeon perspective. I'll talk a little bit about the burden of injury, some interesting stuff on the GCS, what I mean by goal-directed therapy when you're taking care of patients with high ICP monitoring, how best to do it, and how you could manage to maximize cerebral oxygenation, the use of tracheostomies, when they should be considered, and some of the challenges around VTE prophylaxis. Do you start heparin or Lovenox early versus late? Is it safe? Is it not safe? A lot of debate about that. So TBI is obviously a very significant problem. It's a very common cause of traumatic death, certainly across the United States, around the world. It probably is one of the most common forms of injury you see in your centers. At most trauma centers, it really involves about 30% of all patients. So you can't avoid it. If you're a general surgeon, you take care of these patients. If you work in an ICU, you take care of these patients, so it's everywhere. It's also extremely expensive, both from the standpoint of disability and death. And across the U.S., probably it's worth about $76 billion a year because of life years lost, lost productivity, and so on. So huge problem. So there's the Brain Trauma Foundation guidelines, which many of you may have heard about. The revisions are coming out shortly. One of the challenges with the Brain Trauma Foundation guidelines is they're not very practical. We worked with a number of neurosurgeons to develop some hopefully practical guidelines around the care of these patients, kind of balancing some of these issues, tracheostomy, VT prophylaxis, assessment of ICP when you have 1,000 other things going on. So these are coming out shortly, but these were borrowed from the Brain Trauma Foundation guidelines. They were made a little bit more practical, and they're very contemporary. This actually hasn't been published yet. It's going to be coming out in the next couple of weeks. So happy birthday. Whose birthday is it? Anybody's birthday? Okay, well, it's the Glasgow Coma Scale's 40th birthday this year. It's a big deal. And this has been around a long time, and it really has truly stood the test of time. How we use the scale has certainly drifted a lot. And this is a very nice article. It's a relatively short article, but it speaks to where the GCS came from and how it should be used, and a lot of other nuances around it. We use it every day. It's actually worth a read. But a few things to notice here. So the Teasdale, who was the original descriptor of the GCS, and others have really changed some of the terms. So for example, now, we don't talk about confused conversation, they're just confused. Inappropriate speech means they can just provide words, not whole sentences. Incomprehensible speech means they just make sounds. And a few other nuances there. But it's worth looking at this to get a refresher on how the GCS is supposed to be used. And one of the components of that document is really describing how to better use the GCS. And a few things came out of reading it. One is we should be describing the responses not as a composite score, so we shouldn't be saying GCS of 8. We should be breaking down the components when we talk about it. In fact, the GCS score refers to the total score. The GCS scale refers to the 3 components. And Teasdale and others really think we should be sticking to the 3 components and writing those in the medical record rather than the total score. The score is probably better when you're looking at research studies and describing populations of patients rather than individual patients. Don't assign a GCS scale point of 1 if it's not necessarily true. So, for example, a patient's intubated, it's 1T. And that helps your trauma registrars capture the data. It helps from a research perspective. It's the right thing to do. Chart and display changes over time. So charting a graphical format is much more informative when you're taking a quick look at the medical record to understand whether there's been a change in the patient's status. I mentioned about using the scale at the bedside and the score, again, total score for classification and research. And it's important to use the scale for prognosis only in combination with other prognostic factors. So don't just write somebody off because their GCS is 4. There's a lot of factors that need to go into making decisions about patients, looking at their CT scan, their pupillary responses, and other important issues. And it's also important to improve standardization in the assessment of patients. And they really speak to developing training instruments and implement quality improvement programs around capture of the GCS. So I know in my institution, if I'm walking around the ICU, I can see a new neurosurgical resident giving the nipple squeeze. Some people do supraorbital pressure, some deep sternal pressure. The nipple squeeze is out. That should not even be considered. There's actually a very nice website that celebrates the 40th birthday of the GCS, and it provides very simple information about how it should be used, how to standardize it in your institution. There's cards, there's videos, so it's worth looking at glasgowcomascale.org when you get home, if you're really bored. Then, in terms of a treatment of TBI, there's a focus on a goal-directed approach. And I won't go through each of these. Many of these things many of you know, but we want to aim for PaCO2s that aren't too low. 35 to 45 is fine. If you have an ICP crisis, you can push lower than 35, but don't be overly aggressive. Keep the blood pressure reasonable, pH reasonable. ICP goals are in the 20 to 25 range rather than a fixed number of 20. If you're looking at cerebral oxygenation, you're aiming for a number of 15 or higher. CPP over 60. We no longer focus on hypothermia except in one circumstance, and I'll provide that later. Glucose, as you see here, serum sodium in the 135 to 145 range. Keep the INR and platelets reasonable, and the hemoglobin more than 7. So who works with neurosurgeons who insist on the hemoglobin being 10? Pretty common. It's actually a little bit of a dialogue at every bedside with TBI patients, particularly most of us who work in the ICU or accept a lower hemoglobin. There's a nice randomized control trial that was just published this past summer that speaks to the equipoise, really, the equivalence of a hemoglobin of 7 versus 10. In fact, the patients who had hemoglobin of 7 had lower rates of DVTs and other thrombotic complications. So it's probably okay to go as low as 7. So intracranial pressure monitoring. It's funny how this is in all the guidelines, but it's not well used. This is the data we have from a TQIP, and each of these hospitals represents a center, the proportion of patients in their center who actually receive an ICP monitor, and you can see a lot of variation. And there's some centers that are very aggressive. 70% of all patients receive ICP monitors in this center, to some centers who never use ICP monitoring. So not everyone has bought into this concept. If you look at ICP monitoring and TQIP, we looked at the relationship between using lots of ICP monitors and outcome, and we found that at the patient level, if you use an ICP monitor, there's about half the risk of death. Interestingly, if you look at centers that use a lot of ICP monitoring versus a little, there's big differences in hospital-related TBI mortality. So these are hospitals in the highest quartile who use a lot of ICP monitors and less ICP monitors, and this is the odds of death. So what you see here is the centers that use a lot more ICP monitoring have lower rates of TBI-related mortality. And then we did some other analysis trying to understand what's going on with the ICP monitor, because surely just putting something in someone's brain can't be the difference between life and death. And when you look at this, ICP monitoring is associated with just a small proportion of all the variation in mortality that occurs across centers, which means there's a lot more happening around the ICP monitor than just its placement. So a couple of things about ICP monitoring. It should not replace the neuro exam or repeat CT scans. And it's indicated in patients who are comatose, GCS less or equal to 8, and evidence of structural damage on the CT scan. There's patients who come in with diffuse axonal injury, shear injury, who have totally normal-looking CT scans, no evidence of high ICP. They probably don't merit ICP monitors. In addition, you might find some patients who don't necessarily have a GCS less than 8, but they're very high risk. They have big frontal or temporal contusions, and those patients, if they're borderline, probably should have an ICP monitor because they can change very quickly. You also might want to consider it in patients undergoing, for example, early operative fixation of femur fractures or tibia, and you want to follow them closely in the operating room. EVDs are preferred because you can not only measure the ICP but also treat the ICP with CSF drainage. So this is preferable if your neurosurgeons would take that approach. Parenchymal monitors, if you don't have neurosurgeons fully engaged and they're willing to teach you how to do this, or you have patients with coagulopathy here, you're concerned about sticking something directly into the brain. What do you do with high ICPs? Well, it's a tiered approach. So patients with high ICP above 20/25, make sure the collar's not too tight, elevate the head of the bed if you can, appropriate sedation and analgesia with short-acting agents, and if they have an EVD in place, then it's intermittent drainage. If you put them on constant drainage, you no longer can measure ICP. And of course, repeat the CT imaging and neuro exams to make sure there's no progression. If there's progression, they might need an operation. So this is tier 1, simple. If they have persistently high ICPs, you go to tier 2. And in this case, if they have a parenchymal monitor, it's time to put in an EVD in so you can get better drainage. And you consider hyperosmolar therapy. Some are fans of mannitol, some are fans of hypertonic saline. They're both okay. It's important to use them safely. If you're using mannitol, maintain euvolemia. You want to maintain CPP, so make sure patients are adequately resuscitated, and watch your serum osmoles, keep them below 320. If you're using hypertonic saline, then make sure that you don't push the sodium over 160. Same idea. Okay, if they persist, then you want to assess cerebral autoregulation. So normally the brain is very good about limiting the impact of high blood pressures on ICP. In a lot of patients with bad head injuries, autoregulation is impaired, which means if you drive up the blood pressure, you also drive up cerebral blood flow and drive up ICP. So a lot of patients aren't autoregulating, so you might want to assess autoregulation by playing with the blood pressure. If the blood pressure goes up and ICP goes up dramatically, then you have to be careful with that blood pressure because you might make the brain worse. Aim for PaCO2 again in the 30 to 35 range, so push it down a little bit. You might want to consider a test bolus of a paralytic. If that works, you might want to consider keeping that as a drip. And again, consider repeat CT scans. Let's say they're persistently high ICP. These are the patients you have to consider a craniectomy, a drip of a neuromuscular blockade, and even consider a barbiturate coma. We typically use propofol now. Some people use thiopental. And we don't typically do this, but what's suggested is that you use continuous EEG monitoring to ensure the appropriate dose for burst suppression, which is what you're trying to achieve with a coma. And you use hypothermia for rescue or salvage therapy. So if nothing else works and you've done everything, then you can start to cool the patient down to 33 and probably not lower than 33. So lots of stuff goes on around the ICP monitor. And one of the things we were interested in when we were looking at this in TQIP is why there were hospitals with lots of ICP monitor use and those with not so much. And we thought maybe the neurosurgeons are more engaged, and that's why they get more ICP monitors in some hospitals. So we surveyed all the hospitals, and we asked a bunch of questions about what happens around the care of TBI patients. And we asked specifically what their trauma medical director felt about the level of neurosurgical engagement. And we ranked this on a scale of 0 to 100, 0 being totally disengaged, not interested, 100 being really engaged. And we looked at the relationship between neurosurgical engagement and ICP monitoring, and you see here there's no relationship at all. So which is interesting. We thought there'd be lots of engagement in centers that do a lot of ICP monitoring. In fact, what was most relevant was this. This is the proportion of patients who get an ICP monitor. These are centers that didn't have a protocol, for example. These centers did have a protocol. If you had a protocol to identify who gets an ICP monitor and an order set that spoke to how you're going to care for these patients with high ICP, you're going to get much more ICP monitoring. So it isn't the neurosurgeon necessarily who will direct this. I would suggest you work with your neurosurgeons and develop protocols to identify the right patient and how to manage this in a tiered approach. But they don't need to be at the bedside on a moment-to-moment basis to provide good care to these patients. So I think that's a good take-home message. What about tracheostomy? So everybody has their own feelings about when the optimal time is for a tracheostomy. And there are some very strong believers in early tracheostomy, strong believers in, well, it doesn't make a difference, let's just do it late. There's questions about whether it reduces the time on the ventilator. Does it lower your risk of VAP, of pneumonia? It clearly is more comfortable for patients. When we looked at this in TQIP, about 30% of patients with isolated TBI undergo tracheostomy. 40% of these are done within 7 days, and the median time is about 8.6 days. 24% of patients develop VAP. So we asked whether we can study this question in TQIP because there's a range of practices, and this is a good sense of what the range of practices are. So this is the median days to tracheostomy, and this is, each of these bars represents a center. So this center, for example, does them really early. The median days is like 2. This center takes its time. It's almost 3 weeks before these patients undergo tracheostomies in this hospital. So lots of variation in how we provide care for these patients. We did a study where we looked at early versus late. We defined early as less than 7 days, late more than 7 days. And we found that in those centers that do a lot of early tracheostomies, typically less than 7 days, there's lower rates of pneumonia, shorter time on the vent, shorter ICU length of stay, and shorter hospital length of stay. This isn't a randomized control trial. In fact, people have tried randomized controlled trials for this population, but the beliefs are so strong, no one's willing to randomize patients. So this is probably not going to get much better than this, and there's certainly a lot of ways to critique this particular study. What about pharmacologic venous thromboembolism prophylaxis? Another very challenging area. Patients with TBI are at high risk for VTE, probably as high as DVT rates of 20 to 30%. And if you look at clinical practice guidelines, they're very vague. So there's guidelines that are published in the journal Chest every few years, and they say start DVT prophylaxis when you feel the risk of bleeding is less or lower. Well, that's very difficult to know, and no one knows when the risk of bleeding is low. So what's the evidence? Well, first of all, this is what's being done at TQIP centers. So these are the portion of patients who have some form of VT prophylaxis. I have here non-heparin and low molecular weight heparin, different types of patients, all blunt multisystem, patients who come in with shock and TBI. So you'll see here that these are patients who receive none. So there's a lot of patients with TBI who never get any prophylaxis, 60%. We're a little more confident in providing DVT prophylaxis to other patients, but we're a little bit more reluctant with TBI patients. And if you look at what they're getting, heparin versus low molecular weight heparin, so we're pretty liberal with providing what's considered to be the standard, low molecular weight heparin for patients with blunt multisystem trauma, patients with shock, not so comfortable giving low molecular weight heparin in patients with TBI. So again, there's a general reluctance to use the right agent to provide the lowest risk of VT prophylaxis. And TBI patients are started typically later. On average, it's about 2 days. TBI patients maybe about 4 days before they get their first dose of drug. And here's another example. So these are blunt multisystem patients in blue, and I'll show you TBI patients in a moment. The proportion of centers that start on day 1 or 2 or 2 or 3 are very high. Probably about 60% of patients in centers are started around day 2 to day 3. You look at TBI patients, no one knows what to do. So there's a big distribution over here, and a lot of patients receive their first dose beyond 7 days if they have TBI. So again, there's not much evidence to guide us here. Many of you may not be familiar with this, but there have been attempts to identify and stratify patients based on the risk of rebleeding. So these are called the Byrne-Norwood criteria. The reference is here, if you want to look that up, and I think these will be available for you over the next month. But patients are divided into low risk for bleeding, moderate risk, and high risk. And low risk, basically, if their head CT is stable at 24 hours, you can start VT prophylaxis. Moderate risk is listed here. And if you have a persistently stable CT scan, that is, the CT hasn't evolved over 72 hours, you can probably start moderate risk patients by 3 days. Then there's high risk patients who've had an ICP, craniotomy, they progressed. The guidelines here, you can either put a filter in, a retrievable filter. My approach would probably be DVT surveillance. If they get a clot, they get a filter, if I can't provide VT prophylaxis. We're not big fans of filters in my place. But this is a general approach that you can use to better direct early therapy for the patients and be relatively safe. So in our guidelines, we have VT prophylaxis can be considered within the first 72 hours following TBI in most patients. And earlier initiation of prophylaxis is safe, certainly within 72 hours if they're at low risk for progression. So you have to tailor the right therapy to the right patient, but we think that we can probably get a lot better than providing no prophylaxis for a week, which is what's being done in a lot of places now. And with that, there's plenty of time for questions, but a few take-home messages. Glasgow Coma Scale, it's called the scale, not the score. Let's work on better standardizing that across centers. And again, glasgowcomascale.org will give you that information. Goal-directed therapy, probably the new information there, it's safe to aim for a hemoglobin of 7 or greater. You don't have to aim for 10 or greater. ICP monitoring, if you want to get more ICP monitoring at your place, then focus on order sets and protocols and consider that tiered approach to ICP management. Tracheostomy, probably the earlier the better. There's going to be a lot of controversy around that. And VT prophylaxis, I think we're seeing a little bit more data suggesting that it's safe to go a little bit earlier. And I know there's a lot of resistance among neurosurgeons about going earlier, but there's increasing pressure to move that needle a little bit more towards the day 3, day 4, rather than day 7+.